So I'd like to introduce Jane Henderson. She is the Provincial Harm Reduction Consultant for the Opioid Dependence Treatment Center of Excellence. She began her career working in frontline community mental health and addictions for several years, and then spent 5 years in senior leadership positions. She manages the provincial naloxone program and responsible for assisting the 4 regional health authorities and surrounding communities with adopting a harm reduction approach in opioid dependence treatment. She has a master in counseling psychology and finished coursework for a PhD in community health medicine with a focus on harm reduction, duty of care, and people with substance use disorder. And she has special interest in social justice and vulnerable populations. And her contact information is provided should you want to ask questions to her after this presentation.
So just as an act of reconciliation, I'd like to acknowledge my place of work as the ancestral homes of the Beothuk and Mi'kmaq people. I also recognize the Inuit, Nunatsiavut, and Nunatuhivut, and the Inuit of Nitassinan as the original people of Labrador. So today we're obviously doing the Harm Reduction 101. Hopefully today is really just to understand the basic concepts and principles of harm reduction. I'm going to tell lots of stories from my career and stories about my learning and stuff like that. We're going to try to recognize when our own practices may be contrary to harm reduction. We're going to reduce stigma and discrimination against people who use substances. Because I still feel that, we've made lots of really great strides in mental health, but I feel like we have not made those same kind of strides in substance use, in particular, injection substance users. I still feel are very, very much stigmatized. And become an advocate for the integration of this harm reduction work in the stuff that we do every day. Okay, so here, guys, is a picture of what about 22,000 people look like, right? This is a concert hall. I wanted to put that there because I wanted us to get a context of how many people have actually died in Canada from an opioid overdose, right? So we started paying attention to these numbers in January of 2016. We knew that, this was something that was happening and that overdoses were on the rise. So since 2016 and December 2020, we have seen about 22,000 people die. We are well over that number now. The COVID has been particularly hard on vulnerable populations. We know that substance users have the rate of overdose has greatly increased. It really, depends on what you're reading, but anywhere from, depending on what you read, 50 to 60% increase in overdose deaths. So unfortunately, we are above those numbers. That is amounting to about 1 Canadian every 49 minutes. About the same number of people have died of COVID, to put it in perspective. So substance use in Canada. So again, I'm more narrowly focused on opioids, even though we are expanding out beyond opioids into just general substances. But in Canada, we've seen about 47,000 deaths linked annually to substance use, and it's estimated that 21% of the population will meet the criteria for addiction in their lifetime, which really amounts to 1 in 5 people. I actually think the numbers are probably a little bit higher than that, because this is just stuff that's reported, right? And alcohol is still the most common substance, with 18, from which people meet the criteria for addiction at 18%. So just taking a little look at what's been going on in Newfoundland regarding opioids. There's the numbers. In 2016, we had 18 deaths, 57 hospitalizations. I won't read the rest. 2020, we have 25 deaths, 61 hospitalizations. I don't mean to rush through those numbers because these are all people that, mattered. And, we talk about numbers and data a lot, but, these are significant. These are people that died very tragically when they probably didn't have to, if we had better responses to this kind of stuff. I will say that the number of hospitalizations is underreported. Hard to know by what percentage, but we do know that most folks who are overdosing tend to not call for help. Certainly not for themselves. And even if they're with someone else, they tend not to call. They tend to use naloxone themselves or hopefully get through the overdose. So again, there's a lot more people overdosing than what these numbers represent. So you guys are nurses, so I'm not going to go too much into this. What is substance use and dependency? I'm sure you guys know this. So it just refers to the use of drugs or alcohol, right? And includes substances like cigarettes, illegal drugs, inhalant solvents. It's even caffeine. It's even, stuff that we kind of probably use on a daily basis, right? That's a substance. So dependence occurs is when a person needs frequent repeated doses of that substance to make them feel normal. And that, I'm going to just kind of dive into that a little more. So a lot of us working in mental health and addictions and that sort of thing, psychiatry, we tend to look at the DSM for diagnosis and treatment of mental health disorders, right? So it's greatly trusted in our field. People believe that it's a valid source. It's certainly well trusted. And I wanted to include their definition of addiction. And I'm going to use the term addiction and substance use kind of interchangeably. I do prefer the term substance use because I find it has less stigma attached to it. But addiction will occur. So addiction is defined as a chronic relapsing disorder characterized by compulsive drug seeking, continued use despite harmful consequences, and long-lasting changes to the brain. It is considered both a complex brain disorder and a mental illness. So I really wanted to highlight a couple of sentences here. So it says that the DSM says that it's done that. Addiction is defined as a chronic relapsing disorder characterized by compulsive drug seeking despite harmful consequences. And as someone who has kind of worked in this field for many, many years, this was probably the hardest thing for me to understand, because the folks that I've worked with, they've lost everything. They lost their house, their job, their car, their health, their teeth, their kids. And when I first kind of started in this work, I didn't understand how all that bad stuff wasn't making them more motivated to get off the substance. I really thought, the more stuff that can happen bad, the more likely someone is to gain sobriety or to gain recovery. And that wasn't the case, right? And I work with a lot of moms, and a lot of the moms I've worked with have had their kids taken, or have had to go through like a lot of parenting kind of turmoil up and down. And I always wondered, like, how can they still use their children? Because as a parent, I can't imagine anything more horrific than someone coming and taking your kids, right? So I really wanted to highlight the fact that it's widely accepted by all the smart people out there involved with this work, is that the use continues despite those harmful consequences. And it's probably why prisons don't work either, right? And it's probably why when a judge gives a sentence that I'm going to release you on recognizance, I'm going to release you with these kind of conditions, one is not to use, and the person uses immediately, and then it's kind of like, well, you didn't learn your lesson type thing. So it's really to really change our attitudes about this. I think we really need to understand that use is going to occur despite harmful consequences, and that there is long-lasting changes in the brain. And this isn't just social work talk or whatever. This is actually, we can actually show these on brain scans now, right? We can actually show how an addicted brain looks and how a non-addicted brain looks, and all the pain centers, and the amygdala, and like how impulse is controlled and all this sort of stuff, right? So if we accept the DSM's definition, which I do, then how can we order abstinence in someone? And how can we not be addressing addiction through a public health model, right? Because most of our efforts are still put into enforcement, right? We'll get to that in a minute. That's something to think about. So here's the spectrum of substance use. So substance use is generally, this is from the Canadian Mental Health Association, and they generally believe there's 4 pieces or 4 points on the scale. So the first one is beneficial. What we're learning and what we know is that there's a whole lot of people using substances, and they're actually having positive side effects from that, right? Positive health effects, right? So that could be the use of coffee or tea in the morning. I know if I don't have my coffee or tea in the morning, I'm not fit to talk to. So I consider that beneficial for me and society. The use of red wine, like moderate consumption of red wine, or even the sacramental use of ayahuasca or peyote, like all that's considered kind of like beneficial. There's like no harms from it. And then there's the casual and non-problematic, and that's where most people fall into, right? So that's like people who use recreationally, people who like go out to dinner and have some drinks, casual use, and has really not a whole lot of negative side effects. And then there's problematic use, and that's when use has started to become negative, and there's been negative consequences associated with that, right? To the individual, to their family, to their friends, to society, or whatever. Some examples of that are like impaired driving, binge drinking, harmful routes of administration, all that kind of stuff is when you really get to see the problematic use. And then there's chronic dependence, and that's what we spend a lot of our attention on, right? So that's when use has become habitual and compulsive, despite all this horrible stuff happening, despite all the chaos that's going on in your life, and losing your kids, and having, not being able to work, and living, losing your home, and all that sort of stuff. That's where we spend most of our attention on. When we look at it, depending on what you read, it's only about 5 to 10% of all substance users actually fall in the chronic dependence category, right? And it's important to note that people can sometimes go back and forth between different points of the spectrum. And another important thing is to understand that we really should let people be a part of putting themselves in a certain category, right? So I tell the story a lot because it was a real eye-opener for me. Like when I first started to do this work, and I first started like counseling and stuff, I had this client. He was a great guy, like graduated like Ivy League school, like had the cool car, and had, wife, kids, all that, house, all that sort of stuff. And he developed a addiction to stimulants. So he was using cocaine. So he was using about an 8 ball of cocaine a day, which is about, I think it's around 3 grams or 3.5 grams or something a day. It's very expensive too. So when he came to see me, he disclosed that he was using, this much cocaine every day. And I was just like, oh my God, like we got to get him off that. Like, that's crazy. And he was living a pretty chaotic life. He had a deviated septum, living back home with his parents, and it was really rough on him. And I wanted to take away that roughness for him. I wanted to take away that substance out of his life for him. Right. So we worked together for several months, and he did end up, lessening his use. And, now I haven't spoken to him in a while, but last I heard he was off cocaine. But I was reflecting with him one day, and I was like, man, I was so worried about you. You were doing an 8 ball a day. It's like $250 a day. Like, I was so stressed out. And, and he looked at me and he said, Jane, he said, if I didn't do that cocaine, I would have killed myself. And I was like, what? He goes, oh yeah, I would have suicided. He's like, I had so much going on. I had so much trauma coming up. I could not live. I could not live without that cocaine. It's the only thing that kept me alive until he worked out some other stuff. So for me, that was a real eye-opening experience, because if someone tells you they're doing an 8 ball of coke a day, the last thing you're going to think is that's beneficial. It doesn't sound beneficial. Lots of harms are coming with that. But to that guy, it actually was the one thing that kept him alive. So he may have been in chronic dependence, but in that stage of his life, he identified that as being beneficial. So I always kind of like think about that, and when I'm working with clients. Okay, so what are opioids? You guys know this. So, fentanyl, oxycodone, oxyneo, morphine. So a lot of times we talk about cocaine here because a lot of the cocaine that's on the streets now, it's been pretty adulterated. So I think the RCMP say when it crosses the border usually from Quebec, it's about 70% pure. But by the time it gets to the street here, it's only anywhere from 25 to 40% pure. So you don't know, right? You really don't know what you're using. Newfoundland was a bit of an anomaly. And I think this is why it counts for our lower kind of overdose death numbers, in that we had a very high number of prescriptions out there for opioids. I think per capita, we had the most in Canada, maybe. So what that meant, or what that led to, is that a lot of the stuff that people were getting on the streets was actually diverted prescriptions, right? So what people were having on the streets was actually like pharmaceutical grade. So we weren't getting the fentanyls. There was no demand here to get the stuff that's made in clandestine labs down in China that does contain fentanyl, carfentanil, all that sort of stuff. So we were a bit of an anomaly. So a couple of years ago, we did start the prescription monitoring program. And that did take, and I can't remember the numbers, guys, I think it was around 2,000 prescriptions off the street. And then we did see a shift in kind of some of the drugs that people were using. Yeah, so, it kind of goes to show, we inadvertently, I guess, had a safe supply with those, diverted prescriptions, right? So what is harm reduction? So harm reduction is there's a million definition, guys. This is the one that I tend to go to a lot because it's pretty easy. It's pretty self-explanatory. So it's just a range of support services and strategies to enhance knowledge, skills, and resources, just with the aim of keeping people safer, right? And to minimize minimize all the bad stuff that can happen from high-risk behaviors. So it's not just drugs, right? It can be sex work. It can be driving. If you put on a seatbelt today and got in your car and went to work, that is harm reduction, because driving is a high-risk behavior, right? So you put a seatbelt on to mitigate some of those risks, right? You're still going to drive, but you're going to do it safer, right? So that's harm reduction, right? In the very, very essence of it. So harm reduction acknowledges that high-risk behaviors occur and are often chronic and ambivalent to change. And again, it was the ambivalence to change. It was, that I really kind of had to figure out for myself when I started doing this work. I really felt that if someone, kind of reaped what they sowed long enough, that they would, this would motivate them to change. It was so, I had to learn so much about the complexities of it all, and that is not how it panned out. And that a punitive approach really wasn't working for a lot of folks, for the majority of folks. So harm reduction recognizes that individuals are experts in their own lives, just like that guy was an expert in his own life about his cocaine use. I thought I was his expert, and it came from a really good place because I care very deeply about my clients. And I wanted to take away the harm, but he was the expert then, not me. I did not know his circumstances, right? So harm reduction is a public health response focused on increasing safety, again, and minimizing all the injury, disease, and death that can be related to high-risk behaviors. And it recognizes that abstinence is not always realistic or even desired, right? And we have to respect people's decision in that, and that we must meet people where they are at, right? And it's important that we do that so that, so people will actually disclose to us the actual conditions of their use, right? How many times does a doctor say, are you off drugs? And our clients will say, oh yeah, for sure. It's like when you go to the dentist and like, how often do you floss? I'm like, oh my God, twice a day. That's a lie, right? So, not to compare, it's two different things, but we really want to know, what we're dealing with when we're working with folks, right? We need to give them that emotional kind of safety that they can do that with us. So harm reduction involves a bunch of strategies, and it can be integrated programs, policies, and practice just with the aim to improve health outcomes. And it is part of the 4 pillars nationally recognized to address substance use, and it goes along with prevention, treatment, enforcement, right? So when we think about the monies, that we kind of dedicate to kind of battling substance use, I looked it up recently because the numbers change a lot, but it costs about $46 billion a year for us to address substance use in Canada. And 75% of that goes to enforcement, which is, jails, the justice system, prosecuting people, all that sort of thing. And the rest of the 25% is divided up between treatment and prevention, and harm reduction gets about 3 to 4% of that budget, right? So we still very much into the punishment enforcement way to battle substance use. I used to work at a place called Choices for Youth. I was director of programs there. It's a great community organization, supports about 1,400 kids annually. And we came up with a definition of harm reduction back in the day. And it's funny because we were already doing harm reduction. I think a lot of you guys are already doing harm reduction. We just didn't call it harm reduction at the time. We just kind of lesser of two evils or whatever, right? So the ED actually came up with this. I like to think I did, but it was really him. So I'll give him credit for it. So it says, in the absence of perfect choices, we help people choose the one that causes them the least harm. We do this so we have the opportunity to work with people again tomorrow. And I really love that definition because it talks about the idea of choices and perfect choices and the absence thereof. So I think for me, like, part of my learning was understanding that the choices I have in front of me are very different than the choices that a lot of the folks that I've worked with have in front of them, right? So it's been really easy for me to make better choices in my life because I've had, because I've had those choices in front of me. It's easy to make good choices when you have good choices, right? And a lot of the folks we work with, their choices are just not good. It's like bad, worse, and horrible, right? And they choose the one that will cause them the least harm, be it physical, emotional, whatever, financial, whatever. We kind of still judge them because they still made a bad choice, right? Well, there's no good choices to be made. How do you make them, right? And there's a bunch of different reasons. I mean, it's a whole other, a whole other discussion, social determinants of health and all that sort of stuff. But we, part of my figuring this stuff out was understanding that, my choices are very different than the person sitting next to me, right? So what does harm reduction look like in Newfoundland? So we have the Opioid Dependence Treatment Center of Excellence. That's where I work, and we inform ODT, which is opioid dependency treatment. We have 4 hubs across Newfoundland. We have actually a split hub in Gander, Grand Falls, and it provides rapid access to methadone or Suboxone, which is the first line of defense. Also provides counseling, social work, all that sort of stuff. Then we have the naloxone distribution program, and I manage that program for the province, and we've given out probably 6,000 kits, I would say, since the inception in 2016. We have needle exchange programs, so our friends at SWAP, which is Safe Works Access programs, give out about 1 million needles across Newfoundland a year through their site, and they mail out a whole pile, 1 million needles. And the City of St. John's has the installation of sharps boxes to help mitigate some of the syringes being found around. And we have some really cool pilot projects coming down the pipes. I can't really get too much into it because I don't want to jump ahead, but we have some, we're doing a really cool pilot project on 5 South A in St. Clair's, which is cardiology, where we're going to be working with providing harm reduction responses to people with substance use with endocarditis. So it's going to be really interesting, and hopefully it will really start to lay some of that groundwork for kind of having a response to those folks who are in, inpatient care and are still using. So the principles of harm reduction, I'm going to get to really quick. The first one, yeah. So harm reduction focuses on harms, right? So the fact that someone is using a drug, illicit drug or whatever, is secondary to the harms that use causes, right? So you have someone coming into emergency. Many times, a lot of the folks we work with get abscesses from using shared needles, and they get, abscesses. So, I think years ago, it was very much like, okay, you have this abscess, you need to stop using drugs. Look what it's doing to you. To the response, a harm reduction response is, okay, listen, you got this abscess. We're going to take care of that abscess right now. Can I talk to you about, how to, safely inject? Can I tell you where you can access new needles? Can I talk to you about naloxone? Can I give you some numbers for opioid dependency treatment? All that. But the primary goal then is just to reduce those harms, right? So the priority is always decrease negative consequences. So while harm reduction emphasizes a change in safer practices, so you can have those really good conversations with people, once you set up that kind of relationship with them about, I'm concerned about your substance use. Are you using used needles? You can have those really great conversations. We have to recognize, though, where they are on the continuum. There's some people who want to use drugs right now and we're going to use drugs, right? So that's a conversation we can have about how to do that safer, which would differ from the conversation for someone who's like, what? Maybe I want to talk about ODT services, right? That kind of thing. So harm reduction is pragmatic, and this is why I love harm reduction. It's a pragmatic response, simply put. So harm reduction says, what? People are going to use substances, right? The non-medical use of psychoactive or mood-altering substances is here to stay. We have done everything we can to get rid of it, right? So we have, we had prohibition, which really, we've had the war on drugs. We've had, we've incarcerated individuals, which, it's been very racist and very discriminatory, and it's rooted in a whole lot of bad things. And guess what? People still use. It ain't going away. What prohibition done is it created stronger drugs that are easier to transport across borders, right? So it's not going to stop. So we need to figure out how we can keep people safer, right? So it's understanding that drug use is complex, right? And chronic dependence with it can bring varying degrees of social harm. So it accepts an individual's decision is based on human rights. So it accepts individuals' decision to use drugs, and no judgment is made to either condemn or support the use of those drugs. So most recently, of course, we've had cannabis decriminalization, legalization. I'd like to think that we're on track maybe to see some decriminalization of some substances. I think the NDP party may have talked about them. I can't even remember. But evidence is showing that, we really need to, figure out, why we do the things we do, and that the war on drugs has been a complete failure, right? So it supports informed decision-making in the context of active use. So yeah, you have someone who's using, okay, I get that. I'm not going to, condemn or support that, but I'm going to tell you, if you are going to use, here's how you can do that. And you can be safer, right? So emphasis is placed on personal choice, responsibility, and management, right? So that helps empower someone as well, right? So the involvement of people who use drugs. So we know that people who use drugs are the best source of information for their own drug use. And it really is kind of moving away from the paternalistic ways that we may have worked with clients, the way I worked with clients, like that guy I worked with, who was doing the 8 ball of coke a day. I felt I knew more than him. Like, I felt I knew what was best for him more than he did. Right. And it came from a really nice spot. Like, it came from a spot that I deeply cared about my client. Right. So it's all about, letting the people who are actually living this life using these substances to actually determine what's best for them. Right. So harm reduction recognizes that they have competency to make the choices to change their lives, and that their active participation is really crucial into working with these folks. So maximizing options. So people who use drugs benefit from a variety of different approaches, like anyone. Some people do super well in AA, right? Like, they want the abstinence-based model, works really well, beautiful, right? Some people do well with religious organizations and identifying with that and doing work there, beautiful. Some people want to continue to use, and we need to provide an approach for them as well, right? So the idea here is that we provide as many approaches as we can and give many people as many options as we can. So we must provide a proper range of access to a bunch of different interventions. I think in Newfoundland, I think there's a bit of a myth that there's this big wait list for ODT services, which is opioid dependency treatment services. And there really isn't. Like, within any of our hubs across the 4 RHAs, last I checked, you can get someone into ODT treatment same day. And if not the same day, depending on if they're doing Suboxone or methadone, you can get them in very quickly. There's a little bit of a different uptake, of course, with methadone, a little more monitoring needed, but we've sent people to ODT hubs and they've gone on Suboxone the same day, right? So there's no wait list. We also have Doorways, which offers quick one-time. And it says one time, but they actually do more than one if needed. Sorry, my cat just jumped up on me. So there is access to services out there. And of course, we must make sure that people can access those, right? So individuals and communities affected by drug use need to be involved in the creation of these harm reduction strategies. So harm reduction also believes in the priority of immediate goals, right? So it starts where the person is at in their drug use, with the immediate focus on the most pressing needs, right? So the person with an abscess, their most important need right then was to figure out the abscess, figure out the raging infection in their arm, right? The next goal might just be getting them a sandwich, right? Because they might not have eaten for 3 days. The next goal might be getting a warm pair of socks, right? This is how, it's prioritizing those immediate goals, right? So it establishes a hierarchy of achievable interventions that can lead to success. And I'm sure a lot of you guys know that incremental gains, when we see clients do little things, they add up to big change. And then I find when a client does take that first step towards saying, using new needles instead of sharing needles, that next time they're going to come, maybe they're going to talk to me about safer injection practices. Maybe they're going to talk to me about reducing use. Maybe they're going to come to me next time and talk about ODT treatment, right? We know that there's a really big snowball effect with this stuff, right? It really empowers people when they start to make those changes, right? So harm reduction, practicing harm reduction is really important. We provide non-judgmental care. And we say that a lot. I feel like we're almost like saying it like a cliche, got to be non-judgmental. And I'll just tell you a story about me. I use myself as an example because why not? You guys can know all about my growth in this area. So when I started working in the community, I worked at Choices for Youth and I was director of programs. And I came into that job, you know, with a whole lot of education, fair bit of experience, but I really felt like I was the most non-judgmental person in the world. I thought I was Susie social worker. I was, you know, accepted everyone as they were, where they were. Really kind of, I was maybe a little even self-righteous about that, right? So the first couple of weeks I was there, we went on this homeless walk. It was like coldest night of the year. So all the staff and all the young people were there, and Choices for Youth has this beautiful program called Mama Moments. It supports young pregnant parenting moms. Beautiful, beautiful program. And I remember we were getting ready for the walk, and some of the moms were standing to the side, and one of them looked about 17 or 18. She looked like a child herself, and she was 8 months pregnant. She was out to here, and there she was puffing away in the smoke. And I remember, I turned red. I remember going, oh my God, like, how dare she do that? I saw red. So I went to one of the coordinators and I was like, what is she doing? We cannot let this happen. Like, look at her smoking. Like, doesn't she care about her unborn baby? And I was really I was angry. And the coordinator looked at me and she said, Jane, she said, 3 months ago, she was in hospital for a valve replacement because she had endocarditis due to heroin use. So right now she's out of hospital and she stopped using heroin. So we're going to let her have her smoke. And I was like, I'm an idiot. Like, I knew right away when she told me that. I knew that I was judging this person and I had no right to, and I had no idea. And I was acting in a self-righteous manner, but I would never do that. I remember when I was pregnant, like, you're frightened to drink caffeine, you're frightened to get highlights put in your hair, and we, and that's what made, good mothers and stuff, and it was very judgmental the way I was treating her. So I think my son would say that I was schooled at that point. But I think about that a lot, right? And it's part of my kind of, I guess, self-reflection on truly being non-judgmental, right? So it's really just meeting people where they are, never providing coercive services. We know coercion doesn't work. We can't mandate someone to participate in something. We can't mandate someone to go to treatment. It never works. So it's about, it's about always being mindful of that. Okay, so practicing harm reduction is about empowerment. I talked about that earlier. So we know that people who use substances actually know more about their lives than anyone else, right? And they certainly know about the harms because they experience it every day, right? That's not to say you can't educate. That's not to say, you know what, I'm worried about you because you're on benzos, and now you're using opioids and that's a contraindication. Like, yes, educate. But I guarantee you the people who are using substances know how bad it is on their lives, right? So harm reduction seeks to empower people who use substances to share information and support with each other in strategies that meet their actual conditions of use, which is super important. We really need people to be in a safe place where they can disclose their actual conditions of use. Over Snowmageddon, we had this young woman who's been doing really well on methadone. And she was a young person and she was living in a basement apartment and she was on the methadone program. So like day 3, or I can't remember, it was day 2 or 3 or whatever, of Snowmageddon, her pharmacy was still closed. So she was unable to get her methadone because at that time there was some silly rule that the pharmacies weren't talking to each other or something. I can't remember. But anyways, the bottom line was she couldn't get her methadone because that pharmacy was closed. So she was in her basement apartment. She had no food left. She was pretty much snowed in. She ran out of smokes and she was going through withdrawal, which I'm lucky that I've never had to experience that. But from what I can gather, it's like the worst sickness, the worst flu you've ever had. And she was alone. She was very sick. So it was recommended that she go to the hospital. Like, we're like, listen, you're in withdrawal, just get to the hospital. Like, this is an emergency. So she went to the hospital, and when she got there, she went to the front of to the reception, and she said, listen, I'm on methadone, and I've been 3 or 4 days or whatever it was without my methadone. I'm feeling really horrible and I need help. And at that point, when she went to sit down again, at that point, they actually put a security detail on that young woman. And she was like writing, and she was like, why is there a security guard here? Like, what am I doing? And really, it was because she was on methadone, and she was being judged, and she didn't kick up a stink or anything. Like, she was just there, really just needing a safe place to be sick. And it wasn't the emergency room that day. She was later released without any methadone, without a naloxone kit, and she immediately went to her to her dealer to use, as I would do, because I can't imagine going through all that. Living in isolation, going through all that, and not having a safe place to be sick, right? So a little bit off topic with empowerment. Yeah. So it's really important that people are safe to be able to tell us what's happening with their lives, right? Without us, and being able to count on us for an appropriate response. I think it's probably the moral of that story. So practicing self-reflection, practicing harm reduction, self-reflection, that's a process that never ends. For some of us, it keeps us awake at night because we're staring at the ceiling going, oh my God, did I handle that situation right? And we're all in caring professions. And I would say all of us care very deeply about the people we work with, but it really is understanding how our personal values and beliefs, come into practice, right? I would say that, the way I was judging that young woman, I'm glad one of the staff actually kind of put me in my place, because I may have said something to her. I may have been like, hey, you're very pregnant, do you have to smoke? I may have done something like that. So it's understanding how our own personal beliefs and values can be reflected in our work. And this course never ends, we should always be self-reflecting. Okay, cultural safety. So cultural safety and harm reduction considers the social and historical context of health and healthcare inequities. So Canada has a proven history of underfunding services and infrastructure for Indigenous folks. We know this. It's shameful. I know more than when I actually wrote this law. It's actually really, really horrible the way we have, treated our Indigenous folks. And this chronic neglect has created injustice and a crisis in Indigenous communities. And just a step further is that people in marginalized groups experience worse health and access to services than non-marginalized groups. And I will say that I believe that. I know that when I've worked in community groups, like, we would never send someone to hospital, or very rarely will we send a vulnerable person to hospital without an advocate, right? Or send them to the PAU without an advocate, because we know that they wouldn't get the care that they would if someone was kind of, looking over them. And it shouldn't be that way. It shouldn't be, you get better healthcare because you have someone to advocate for you. It should be kind of, this is the healthcare that we're committed to giving this person, and it doesn't matter, what else is happening. So it really is up to us to give that culturally sensitive care to clients. This can be reflected in our policies, procedures, training, access, communications, all that kind of stuff. And it's also recognizing that the horrible way that a lot of folks have been treated, and the Indigenous folks, LGBTQ2S, homeless folks, any marginalized group, has really created a distrust, in some of the services that we provide. And, I think for good reason, depending on what you read, it says it can take anyone like 5 to 7 times, I can't remember the exact number, for someone to actually go through with reaching out for help. And, when someone presents in hospital for whatever, right, whether they're considered drug seekers or not, it really doesn't matter to me. It's about taking that opportunity we have with that client or that patient and figuring out how we can build on it, right? And it's really seizing that opportunity, right? Okay, strength-based approach. So harm reduction believes in a strength-based approach. And it really focuses on people's strengths versus the labels, right? So it builds on clients' abilities by saying the person is not the problem is the problem, right? So I've worked with some of my favorite people I've worked with are former clients. So some of my favorite people are people I've worked with, like my former clients. Their resiliency, their genuine, authentic, care for other people. I really, really, as I've said earlier, care very deeply about a lot of the folks I've worked with. And I've understood that a lot of times people have made some bad decisions. Good people make bad choices sometimes. And that the problem is not the person, the problem is the problem, right? So it's trying to kind of separate those two, I think is really important. So it'd be hard to talk about harm reduction, not talk about trauma. So clinical studies have found that over 80% of clients with substance use had experienced abuse as children. I would think that number is even higher than that. Like I did when I was writing some work for my PhD, I looked through 8 years of my client files and I reflected on it, and I could not think of one female who wasn't sexually abused as a child. We're talking chronic substance users. And with the men, it was about 60 to 70%, right? So we know that male and female sexual abuse survivors experience a higher rate of alcohol and drugs, substance use disorders, and that they make that choice a lot of times in an effort to manage their trauma. And I can't tell you how that is 100% true, right? Causation, correlation, I get it. But in my experience, most of the clients I've worked with, 99.999, have had some really, really traumatic experiences happen to them, right? I include this: approximately 75% of homeless population use drugs or alcohol as a means to self-medicate to deal with the traumatic experiences and abuse they face. I wanted to include that because I feel that since we're talking about marginalized groups, I really feel the homeless folks are really, really marginalized. And I think that you even see it on kind of sometimes on Facebook and social media, you see memes and stuff, go get a job or, something like that, or, but what I wanted to say about that is that what I learned is that there's not a whole lot of difference between myself and someone who's homeless, right? And if you truly knew the stories of the people that we work with, it would break your heart, right? I'm out of frontline work largely because, I couldn't even, sometimes, you get this, secondary trauma and stuff. And I'm sure a lot of you guys have heard some pretty, really horrible stories about, and it involves system failure. It involves us not protecting kids the way we need to. And I can say very confidently that if I lost my house, my car, my job, my kids, I'd 100% turn to substances to deal with it. And, we live in such a society where there's such a double standard, because when Snowmageddon hit or when the pandemic hit, it was very almost in vogue for guys or girls to be out in the shed drinking and saying, hey, it's 5 o'clock somewhere, drinking at 10 o'clock in the morning or whatever, because it was, it was a way for them to deal with, a very weird time in the world, but, especially with the pandemic. All my girlfriends, for example, we would get on FaceTime at 5 o'clock during the pandemic and be like, hey, it's wine time, but it was really accepted for us to do that because we were coping with having the kids home all day and out of school and just this bizarre world we were living in. But if you're poor and you don't have a house and you live on the street and you use drugs or alcohol to make yourself feel better, you're really looked down on and judged, So it's really, I just want to include that there just to kind of challenge our thinking a little bit. And I do give, when I have money, I give money to homeless folks. I don't care if they buy drugs or alcohol for it. I've also bought meals. So if someone says, can I have some money? I'm hungry. I'll say, sure, let's go to Subway. I'll get you a sub or whatever, go to McDonald's or whatever. Or if I have a couple of bucks, I'll give it to them. And you know what, if they need to self-medicate that way, Why is it okay when I do it and not them, right? Okay, so trauma continued. So trauma awareness is about being aware of the prevalence of traumatic experience people who use substances and its impact on development and relationships, your physical, mental, and mental health, right? So I don't know if you guys have done trauma-informed practice. I think it's wonderful. I think everyone should do it. So being trauma-informed involves providing safety, control, and connection to folks. And it really is about that emotional safety, right? So that is involved in our relationships that we build with folks, right? So that includes patients, including patients in treatment processes, screening for trauma. And I gotta say, you don't need to know someone's trauma or that someone has had trauma in order to treat them in a trauma-informed way. And actually, I would actually very, very kind of firmly say, you shouldn't know their trauma, because trauma is a very specific subset in counseling. Like, I have my master's in counseling, and when I had someone with significant, say, childhood trauma, I would refer them to a trauma specialist, right? I would help bridge that gap for them until they could get in to see someone. But trauma is very tricky, and we never want to re-traumatize someone. And sometimes bringing up past trauma can actually do that. So that's why I always refer it, to an expert. So we can be trauma informed by training staff and trauma specific treatment approaches, and engaging referral sources and partnering organizations. And again, guys, at the end of the day, it's all about that emotional safety. The more folks know that we care about them and genuinely care about their well-being, and take them exactly as they are right now in front of us and care about their health, the better safety they're going to feel, right? So here's some myths and realities. So there's a myth out there that harm reduction increases crime and public disorder, and that is false. It can actually lead to a decrease in public disorder. So like, there's this kind of myth that, if we put a needle exchange site here, or if we put a halfway house here, it's going to be police and drugs and all this kind of stuff. And it's not the case. I live in Cont Heights, and I have these wonderful neighbors. I tell the story sometimes. I feel really guilty telling it, but I have these wonderful neighbors. We share like tomato plants, and like they watch my house when I go on vacation. These lovely people, right? And one day they came to my door, and they're like, Jane, they're like, next door they're going to be putting a key assets house. So here's a petition, to sign so that they won't operate that, because it's going to bring our property value down. We're going to have drugs everywhere and sex workers and all this sort of stuff. And I was like, oh God, these people don't know me at all. So I didn't sign it because, I think at the end of the day, I was more upset that as a parent, it was okay for my 2 kids to live in Cont Heights on a safe street with a park across the road, where they could ride their bikes and they could just be kids. It's okay for my kids to live in Cont Heights, but it's not okay for these kids next door to live in Cont Heights, right? And that made me really sad, that we still continue to make decisions for other people's kids and for other people that we would never make for our own kids or our own family members. So my point is, key assets did move next door. And it was a long-term situation for some of the young people there, and they're lovely. I've developed relationships with kids. They're not kids, they're teens. Police have been there sometimes, and I don't care. They've been there like twice, maybe in 3 or 4 years, and it's none of my business, right? Yeah, so that is a myth, right? Actually, it can lead to a decrease of anything. If you open a safe injection site, many times when it has been open in areas of high use, it actually, I don't want to use the word cleaned up the city, because I don't want anyone to think people who use substances are dirty, but it actually led to, obviously decreased overdoses, but it also resulted in like less discarded drug paraphernalia, less needles and stuff like that. And people had a safe place to go and do their substances, right? And we talk about, there's a lot of opposition for safe consumption sites, but like a bar is a safe consumption site, right? So you go downtown and you go to Raleigh's or wherever, that's a safe consumption site. Your drug supply, drugs, alcohol, your alcohol is regulated by the NLC. You know what you're getting. And there's staff there that will call, police if you pass out, or an ambulance. That is we already have safe injection. We already have safe consumption sites, right? They're called bars. So a lot of people think that harm reduction is anti-abstinence. It's really not. We focus on anti-abstinence because we really need to emphasize that abstinence is not always realistic or desired by a lot of folks, but it's simply on the continuum. Right. I have folks who do very well in abstinence-based programs, and I love it for them. I'm happy for them. Some folks don't. So we need to have a response for those folks as well. Right. So there's some myths out there that enables and promotes drug use. There is zero compelling evidence about this. I have needles all over my house. I have naloxone kits all over my house. I have 2 teenagers. Well, I have a preteen and a teenager, and my house is like Grand Central Station. People are going in that all day. I'm very confident that that's not increasing my children's likelihood they're going to use drugs. There's a myth that harm reduction is ineffective. That is a lie. To save countless numbers of lives, I would not want to see the number of deaths that we see, especially out west. If we didn't have naloxone, we know that people are getting Narcan 3-4 times a day. So it has saved a lot. I responded to an overdose randomly a couple of months ago. I was driving my car 6:30 at night. Someone had passed out, and there's a bunch of people around them, and I just happened to be driving past, and my trunk is full of naloxone kits, and I thought the man was dead. And once I naloxed him, he came back within 30 seconds. Right. So nobody can tell me it's ineffective. There's a myth that harm reduction takes resources from treatment. That is not the case. We know that the majority of our funding goes towards enforcing drug laws, and that very little has actually gone to harm reduction. And we know that needle syringe programs, which is probably the most common harm reduction initiative, is the most cost-effective public health intervention ever funded, right? So harm reduction is the only global drug policy response that has been proven to save lives and money while increasing quality of life. Harm reduction has not been shown to increase or encourage substance use, nor does it increase the number of new substance users. There's zero evidence of that, guys. Harm reduction reduces stigma and increases referrals to support programs for people who are struggling with substance use, and can encourage people who use substances to start treatment. And I've seen this happen, guys. Like, I've seen people who cared very little sometimes about whether they were around the next day or not. I've seen them take little steps. And the snowball effect is a real thing, right? So harm reduction reduces crime and increases employment for folks who use substances. I've seen that as well. 2/3 of Canadians actually support harm reduction as a general approach to substance use. And Canada is recognized as an international leader, and the opening of safe injection sites does not increase arrests for drug trafficking, assaults, or robberies. I think it makes the community safer. So this is just a little bit about stigma. I'm going to go really quickly through this because I think I'm running out of time. Yeah. So we know that stigma is, negative attitudes and beliefs, and that stigma can cause isolation, feelings of shame, guilt, worthlessness, increase high-risk behavior and risk of death. And I think about that young person who went to hospital because she was withdrawing from methadone. She felt stigmatized, right? Not only did she not get methadone that day, not only did we say, well, we can't give you methadone, go home and suffer it out, but we put security detail on her, right? This like young woman who's never hurt anyone, right? So we know that she's, we know that that is stigma, right? And self-stigma is when someone internalizes that, right? I've had clients who've told me the thing that keeps me using is the shame. I feel so ashamed and I feel so stigmatized, right? And it really prohibits people from reaching out and getting the help they need, right? So a few years ago, a bunch of smart people in Eastern Health came together and they surveyed a bunch of people and found out that most Eastern Health employees had a good understanding of addiction. But at the end of the day, the perception was that addiction is based on choice, right? And when we're able to say, that's your choice, we're also able to say, too bad, I'm done, I'm washing my hands clean of you, right? And studies have shown that the way we work with people who use substances really can impact client outcomes, right? And it's just, I've seen it so many times. There's certain doctors that folks won't go to, right? But there's certain doctors that have 150 clients, you know what I mean? And people know when they're being stigmatized, right? It's not a good feeling. So structural stigmas occur when we don't take requests seriously and we don't connect them to health or social services. And it's really okay to say, you know what, I care about you a whole lot, but I'm not the person, you know, that you need to talk to, but I'm going to find you someone who will talk to you. How about you call this number? How about I call for you and set an appointment? You know, anything like that is awesome. You know, can certainly help connecting folks to those services. Because I'm running out of time. Yeah. So there's two really great resources I want to kind of bring you guys attention to, and that is the harm reduction and illicit substance use. This is by the Canadian Nursing Association. Great resource. You got lots of support coming from your association around harm reduction. There's also a joint position statement on harm reduction from the Canadian Nurses Association and the Canadian Association of Nurses and HIV and the Harm Reduction Nurses Association. Whole lot of really great resources out there if you're interested in doing this. And we're at a bit of a weird time where, like, not all of our policy matches our philosophy, you know, and when in doubt, you can always reach out. We can always talk about, you know, giving a harm reduction consult or stuff like that. And this stuff, I think I'm pretty much done. I would like to say that, you know, a lot of us grew up in a time where we learned drugs are bad. Just say no, drugs are bad, drugs are bad. Don't do drugs. If you do drugs, you're bad, right? And that was particularly harmful for a whole lot of people, especially kids who went home and saw mom and dad using substances. We know 1 in 5 people use substances, right? So when we were, you know, listening to this kind of stuff, a lot of kids went home and kind of really began to think mom and dad are bad, or when they began using substances that they were bad, right? So it's hard to undo a lot of those things, right? And it was really, you know, in the 80s when we really started to focus on the crime, substance use as a crime, right? As a moral weakness, and it had to be dealt with in an enforcement way. So we had to arrest people. We had to get tough on substances, tough on drugs and stuff. And it really just, it created this prison complex system. It was just, it was very unsuccessful. And I just thought, you know, if we want to think about how substance use is still viewed, there's still 30 countries that retain the death penalty if someone's using substance. You know, you'll get killed. They will put you to death if they find that you're using substances. So I think there's been great strides, but I think there's lots of work to do. And I think just to highlight some things in nursing that a lot of nurses are doing now is the needle distribution. You know, if you can't give needles to your clients, it's really easy to give them the number to swap who can help with that. Opioid overdose strategies. So if someone is, you know, someone's using, you can provide some really great harm reduction messaging around overdose prevention, you know, carrying a naloxone kit, all that sort of stuff. Lots of methadone and detox and maintenance happening now in nursing. Buprenorphine, which is buprenorphine and naloxone, which is Suboxone therapy. Love to see that happen at all bedsides where possible. There's I might be wrong saying this because I only read these words, I don't actually hear them, but it's diacetylmorphine, which is the heroin therapy, which a lot of nurses are trained in. Supervised consumption sites, injection sites. We have lots of great nurses working there. We have the harm reduction nurses here in town who are just fabulous, always giving clients information on safer use and supplies. And understanding that it really is this holistic approach, right? So it's really about housing. To me, it's about key life factors, right? Housing, education, employment, but understanding, you know, like Maslow's hierarchy of needs, that many times with substance use, we expect people to be up here on the hierarchy, but we haven't really done anything about their basic need, which is like food, shelter, clothing, that sort of stuff, right? And really, that's it.